We are actually very excited to be here and talk in front of you about our three main cancers: ovarian, endometrial, and cervical cancer. I will focus on endometrial cancer, the most frequent cancer found in women that originates from the pelvis. And I always tell my patients, if you have to pick a cancer and develop one that comes from the gynecologic organs, pick this one, because that's the easiest one to cure, because mostly it shows up the earliest. So endometrial cancer, as I said, affects women. In 2015, about 54,000 are estimated to have this diagnosis. And about 10,000 women still die of this disease. So we can't save everybody, but we can save a significant number of patients. What this number doesn't tell you that nowadays we have at least 20% of our women are under the age of 40. And a lot of those women have not completed childbearing. And there's many reasons why, obesity being one of the main risk factors. And we all know that our children, teenagers, nowadays are facing the issue of obesity more and more. When you compare ovarian, cervical, and uterine cancer in terms of the outcome or prognosis, and this slide, again, just published in 2015, tells you some important information. The numbers indicate the percentage of patients that are alive after 5 years after diagnosis. If you take all stages, so the very early stage 1, 2, also 3 and 4 together, about 45% of patients are alive when they have ovarian cancer. About 68% are alive when they have cervical cancer. And in endometrial cancer, 82% of patients are alive. So it's, again, as I said, the cancer with the best prognosis. All of our cancers are very well treatable if they're local, but as soon as they start spreading here into the pelvis, the prognosis gets worse. And at distant disease site, that means the cancer has now gone to the liver, lymph nodes, and the lungs. The prognosis really drops significantly, but the ovary is still the best. About a third of our patients are alive after 5 years, even if they have advanced disease. But not so in endometrial and cervical cancer, with 16 and 18% after 5 years. That is mainly a reflection on how little chemotherapy sensitive these cancers in general are. Ovarian cancer responds well to chemotherapy. Cervical cancer and endometrial cancer, not quite as well. We used to look at least at endometrial cancer divided into two different subtypes. There's a type 1 and type 2. The median age at the time of diagnosis is about 10 years younger in type 1 and type 2. Type 1, definitely the most common one, and that's the one that actually is related to obesity. There are precursor forms, hyperplasia, complex atypical hyperplasia, can lead in about 40% of patients to the development of invasive adenocarcinomas. There are very specific molecular alterations, PTEN and KRAS, for example, compared to type 2, which has different molecular alterations. The histology, so when the pathologists look under the microscope, will tell you, well, those are endometrioid type of cancers, versus those cancers from type 2 are more called serous and clear cell. And this last type is the one that is even more resistant to chemotherapy. And we do see the prognosis of these patients being much worse than this type 1 endometrial cancer. Now keep that in mind now, and that's the paradigm we've followed for a couple of decades. And till recently, didn't really know so much better how to group these cancers. This is a study that was published now almost 2 years ago. This is a very detailed and sophisticated analysis of the genetic makeup of endometrial cancer by the Cancer Genome Atlas. And without going into any details here, it seems like endometrial cancers have a lot of different molecular alterations, many more than we thought they would have. The other interesting thing from the study was that some of the cancers that we consider rather good prognostic cancers, benign cancers, actually don't behave so well because they have certain molecular alterations that make them behave really bad. Those are early stage cancer, early grades that recur very quickly, and again, pose for us a really significant therapeutic problem. But this is nothing we're using these days, but this is where our field is heading now. Now, endometrial cancer is caused much by estrogen. We for many years have known if you give women estrogen only, women that have a uterus, you do increase the risk of developing endometrial cancer. That's why as hormone replacement therapy, we recommend doing 2 hormone treatments, estrogen and progesterone, because the progesterone keeps that estrogen in a balance. The pathology, as I said before, it comes from the inside of the uterus. It can grow into the wall of the uterus, spread to the fallopian tubes, ovaries, but also in local lymph nodes and distant sites, liver and lungs. Symptoms are usually non-menstrual bleeding. Patients in menopause present with bleeding that they haven't had for a long time. There can be very heavy bleeding, even during irregular menses. There can be pain during urination or intercourse. Some patients even feel, or the doctor feels, a mass in the pelvic area. And in advanced diseases mostly, patients report weight loss. So all these symptoms should prompt the physician, the OBGYN, to think about the possible diagnosis of endometrial cancer. We do a pelvic exam to diagnose this disease. A pap smear usually detects cervical cancer, but at times also has cancer cells that come from high up in the uterus, and they show as cancer cells on the pap smear. But it is not a screening test for endometrial cancer. We do endometrial biopsies. Those are easily done in the office. We insert a very tiny, small plastic tube inside the uterus. It's like, as I call it, a big pap smear that allows us to get some of this tissue. Sometimes we have to take a camera and look inside the uterus. It's called a hysteroscopy. We can, with this, also retrieve some tissue, send it to the pathologist, and they will tell us whether we deal with endometrial cancer. The treatment is usually surgery. We take out the uterus, hysterectomy, the fallopian tubes and ovaries. We also need to know whether lymph nodes are involved, and therefore take out lymph nodes in the pelvis and around the aorta, that big artery in the mid of the abdomen. Some of our patients need radiation therapy following surgery, or even primary radiation therapy in cases where you can't do surgery. Some of our patients need chemotherapy and hormone therapy with progesterone, or even anti-estrogens like tamoxifen has been used. So it's a quickly developing field with a lot of therapeutic options, and those of you who want to have a more detailed discussion about these type of topics are welcome to approach us either after this talk or in our clinic. But the talk today is more really focused on how can we prevent endometrial cancer, what are the risk factors, and what can we do about this. So here you see actually an extensive list of risk factors that we know of. Early menarche, the first time a woman has a period, if this is early on, here age less than 12 years, or the menopause is really late, a woman goes through many menstrual cycles, and that increases the risk of endometrial cancer. If a woman is infertile or never had children, that also increases the risk of endometrial cancer. Obesity, as I mentioned, is a major risk factor. We just had data from an Australian study that actually showed that with a body mass index, a way to measure your obesity level over 40, your risk of getting endometrial cancer is about 10-fold higher. And that's a huge number. Patients with breast cancer that are treated with tamoxifen have a slightly increased risk of developing endometrial cancer. It is not as high as to warrant screening for it, though. Estrogen replacement therapy, we talked about this. If it's unopposed by progesterone, can increase your risk of developing this. And animal fat, diets that are very high in animal fat, do increase your risk of being obese and do also increase your risk of developing cancer. Lack of exercise kind of feeds into the same paradigm. Diabetes has been known for a long time to be a risk factor, and you do not have to be obese with diabetes to have an increased risk of developing this cancer. Then age is always a risk factor for cancer. Caucasian women develop it more often. And then very important is this, and I'll talk about this some more. There are certain families that have genetic mutations, in particular those families within the hereditary non-polyposis colon cancer, or HNPCC syndrome. It's also called Lynch Syndrome. If a woman has a personal history of breast or ovarian cancer, her risk of endometrial cancer goes up, and prior radiation therapy for pelvic cancer can increase your risk of certain cancers from the uterus, particularly sarcomas. And this effect is usually late by about 20 years, but we see a clear correlation between prior radiation treatment and risk of endometrial cancer. Now, there are factors that reduce the risk of endometrial cancer. Oral contraceptives, for a long time, have been known to reduce it by about 50%. Tobacco. Now, I'm not proclaiming this as a prevention strategy here. Please do not smoke. But what it interestingly does is smokers have lower levels of estrogen and lower rate of obesity. And those two reasons probably account for the fact that tobacco smokers have a lower risk to develop this particular cancer. Intrauterine devices, either the copper one or the progesterone one, seem to lower the risk of endometrial cancer. Actually, as a matter of fact, the progesterone-loaded IUD we use for the treatment of early forms of endometrial cancer and even endometrial cancer itself. Exercise, as I said, lack of exercise seem to be associated with increased risk, but if you exercise, you do improve your metabolism and also decrease your weight, and that relates in less risk. And then diets, and that's really a field where all of us can actually make a difference. It's interesting that whole grains, veggies, fruits, seaweed increases estrogen excretion, meaning the body all of a sudden has a greater ability to get rid of estrogen, and it also decreases estrogen reuptake. So whatever you can do to reduce your estrogen level in your systemic circulation in your body will ultimately decrease the risk of developing this cancer. Now, I'll show you here a family. This picture was taken in 1913. And this was taken actually with this person here, Aldred Wathen. He was the first one who actually identified a family, and this is a family of a seamstress, that had stomach and endometrial cancer. He realized that this actually might run in the family. Of course, in 1913, he didn't have the molecular tools that we have available right now, but he took a picture with this family here. Here are the affected individual on this panel. And it was only 50 years or so later that Henry Lynch went ahead and named this syndrome, which is now called the Lynch Syndrome. And this really has opened a fabulous opportunity for us to screen and identify patients that are high risk for developing endometrial cancer based on their germline mutations. And I'll show you what type of cancers these patients develop. It's not only endometrial cancer, it's colorectal, ovarian, gastric, small bowel cancers. But if you focus in on endometrial cancer, depending on the mutations that these patients have, up to 2/3 of all patients in their lifetime develop endometrial cancer. It's a huge number. Now, why do they develop endometrial cancer? Well, the genetic defects have much to do with DNA. This is a double-strand DNA here, and as the cells in our bodies, even the normal cells, are dividing, they have to make new DNA. During this process, this DNA, what we call replication, makes mistakes, and these mistakes have to be repaired by the cell. If the cell cannot do that, then the cell either dies or it continues as a mutated cell. And if you have the right mutations, it will eventually develop into a cancer cell. We know a lot about these genes, and there's still some to be identified, but I just want to point out the ones that we clinically use now: MLH1, MSH2, MSH6, and PMS2. I will show you in a moment how we use them. So those are the genes that your genetic counselor will ask for if they want to test you for potentially being one of the Lynch syndrome patients. Now, who do you want to test actually? Not everybody. It's not a screening test, because only about 5% of endometrial cancers, as far as we know nowadays, has a genetic predisposition. But we test those patients that have endometrial or colorectal cancer, that have certain molecular features in their tumors. We also want to have first-degree relatives that are affected with endometrial or colorectal cancer, who were either diagnosed before age 60 or who are identified to be at risk for Lynch syndrome by a systematic clinical screen that incorporates a focus on personal medical history. Now, those are all very sophisticated algorithms that any genetic counselor will plug you into. If you go and sit down with them, if you're concerned about this, make an appointment with one of the Stanford genetic counselors. They will take a very detailed history. Very, very important, because sometimes it's really what you're telling them that prompts them to test you or advise against it. And then, of course, if you have a first or second degree relative with a known mutation that is part of the Lynch syndrome entity, please go and see the genetic counselor. You might be part of this syndrome. Now, what does it look like? Here's tumor tissue. This is what it looks like under the microscope. When we test for these proteins, we basically color those proteins. Here is when this is all brown. This is when the proteins are present, and here's when they're absent. And this could very well be a patient with Lynch syndrome. So if you get your endometrial cancer surgery here at Stanford and other institutions, our pathologist will tell us, well, the protein is present, you don't have to worry about it. Or the protein is absent, yes, we absolutely should test you as a patient. And that will allow us to identify you as a genetic carrier and then also allow us to test your family members, which is very, very important. Now, it gets more complicated, but suffice to say that we test, again, every patient that has endometrial cancer here for the proteins. If the proteins are absent, these proteins, genetic testing is eventually recommended. And in some proteins, we actually do additional testing for promoter methylation, and if the methylation is absent, then we channel the patient towards genetic sequencing and identification of certain mutations. These algorithms have been vetted and changed over time, and they're still in the process of being changed, but that is why we need very sophisticated, very educated advisors and people that can follow these algorithms. Screening and surveillance recommendation for women with Lynch syndrome. This is our American College of OBGYN in November 2014 said that, well, if you have Lynch syndrome, do a colonoscopy for colon cancer every 1 or 2 years. You begin at the age of 20 to 25 years. That's very early on because the risk of colon cancer is in a 70% range for these patients, even higher. For endometrial cancer, you want to do an endometrial biopsy every 1 to 2 years, and you begin at the age of 30 to 35. That's also very early on in life, and that's the little plastic tube that you put in the uterus and get some tissue. And you also should keep a menstrual calendar, make sure you don't have any abnormal bleeding between your periods, and anytime you have this, please consult your physician. Now, with Lynch syndrome, we actually have a preventive strategy, and this is taking out the uterus. This is a prophylactic hysterectomy with removal of the fallopian tubes and ovaries, which was shown to really work well in a publication almost 10 years ago here by Karen Liu. And if you look at this graph, that's one of the sentinel figures from this publication. Patients that had a hysterectomy literally developed no endometrial cancer over the 20-year observation period. And patients that did not have a hysterectomy had the up to 60% incidence of endometrial cancer. So surgery for Lynch syndrome does work. So I want to summarize this here. As I said, endometrial cancer will affect about 54,000 women in 2015. One of the most modifiable risk factors is obesity, exercise, diet. Those are all things that everyone can do. There's no recommended screening strategy for the general population. We don't do ultrasounds for endometrial cancer for screening. We don't have a pap smear for it. But we recommend that patients with Lynch syndrome that are very high risk of developing endometrial cancer, those patients need surveillance, as I said. So I want to thank you here, and I know the podium is open for questions later on. This is where we do our work here at the Stanford Women's Cancer Center in, of course, close collaboration and support of the Stanford Cancer Institute. Thank you.